All right, let me get my whiteboard rolling here. Yeah, we have everybody, right? We're all here, as far as I know. All right, cool. So here we go. So we're going to talk about different pathologies at the wrist and hand. We're going to spend a lot of time on the wrist today, though, mainly because there's actually a lot going on there that we actually need to talk about. So within the wrist, obviously, there are a lot of different pathologies that we can see, but the main ones that we're going to cover, at least today, right, we're going to cover essentially fractures, okay, fractures of the carpals, dislocations, sprains, and then obviously compressive neuropathies. All right, so ultimately, right, when we talk about the wrist, okay, it's really important to note that the wrist is actually the wrist is actually very prone to compressive injury and fracture, right? With compressive injury. So ultimately, what do you guys think is one of the main mechanisms by which wrist sprains occur? What do you think that would be? If the wrist is most prone to fracture and compression, what do you think? What would that mechanism be called?
Like a traumatic one, or like just falling?
So generally speaking, so yeah, it's traumatic, right? And a lot of those compressive injuries typically occur via falls. But what type of, there's a specific acronym that I'm looking for when we talk about essentially those types of falls that result in compressive injury and fracture. Anybody remember what that's called? Starts with an F.
A foosh.
A foosh, correct. Okay, foosh. All right, so a fall on the outstretched hand. I can spell stretched. Outstretched. There we go. Better. Okay, so ultimately, look, the scaphoid. Okay, when we look at this bone, I'm gonna draw for you guys, and I'll pull up a picture here in a second as well. But here's the deal. Okay, the scaphoid. All right, as we know and understand this bone. Okay, it's essentially shaped like this. Wow. Okay. All right, and then next to this bone is the lunate. So the thing about it is the scaphoid has essentially a head and a neck. The scaphoid itself, right, can break typically anywhere, but it typically breaks at the head and neck junction, right? So you'll typically see like a fracture here, or even maybe here mainly, right? Generally, these are not so much mid-substance all the time. However, the thing about scaphoid injuries is that scaphoid injuries have a really horrible time healing. Okay, scaphoid fractures are notorious for not healing well. Okay, and so it can be more common than not for scaphoid fractures to go on to require surgery with pinning, right, and or potentially develop avascular necrosis, right? So ultimately, okay, many scaphoid fractures require surgical pinning or a screw, right? But they are, but these injuries are notoriously bad healers. All right. All right, so that ultimately can lead to what's called a vascular necrosis of the wrist. Who can tell me, by the way, and I know you guys have probably heard that before, what is avascular necrosis?
Isn't it basically when like the tissue dies because it has no blood supply?
Correct. Absolutely. So the tissue dies because it has no blood supply. Okay. Avascular necrosis of the wrist is called Kienbock's disease. So you may want to remember that. This is being recorded as well. So this will be recorded for you guys. But yeah, avascular necrosis of the wrist is called Kienbock's disease. So let's actually pull up a picture here, okay, of a scaphoid fracture. I want to show you guys exactly, what this might look like actually on X-ray. All right, so you guys can see that, yeah? Okay.
Yeah.
All right, so, okay, clearly, so we have the scaphoid here, obviously, right? And you can see, this really, really obvious, kind of opaque line through the scaphoid here, right? And also down at the bottom as well. Okay, you can see, the fracture there. And here's the deal. You can even see, okay, you can imagine how a fall, okay, onto the outstretched hand with the wrist extended, okay, is going to essentially take that first metacarpal and that radial head and compress them together, right? That would make sense, right? And so the only thing essentially there to take up that compressive force in the middle is the scaphoid, right? So that's all that's dual, that's all that's there anatomically to take up that force. It's also common with those types of mechanisms that you may get also a concurrent distal radius fracture. That does happen sometimes as well. Okay. So here's a question for you guys. If we're taking care of someone with a scaphoid fracture, how do you think we should splint them or cast them? Should they be in something that also immobilizes the thumb up to the DIP, or should the thumb be free? What do you think?
I think you should splint the thumb too.
Okay, Nico, why do you say that? You're right. Why do you say that?
Doesn't the muscles of the thumb run through or run by the scaphoid, don't they?
Okay, so remember, yeah, the scaphoid lives right in that anatomical snuff box, right? That is outlined by which two tendons? Who can tell me which two tendons make up that anatomical snuff box?
Is it the extensor and flexor of the profundus? Not profundus. I don't know what my thumb's called now.
You got it. Yeah. So it's my extensors, right? My pollicis, extensor pollicis. Okay, I've got my longus and my brevis. And those two things together make up the anatomical snuff box, right? In which lives my scaphoid. All right. Nice job. Nice job. Okay. So, but Nico, yeah, you're absolutely right. We need to splint the thumb, okay? Because if you can see, right, movement of the thumb, particularly if I terminally kind of abduct and oppose my thumb, or adduct and oppose my thumb, I can actually feel the tendons move, and it actually kind of makes that scaphoid more prominent in the snuff box. So I have to, we lost somebody maybe. So ultimately, right, I have to immobilize the thumb to keep the scaphoid stable. Okay, so if we're splinting somebody or casting somebody with a suspected or confirmed scaphoid fracture, we need to make sure we include the thumb. Okay, now, welcome back. Here's the next thing. All right, what bone? And we established this yesterday. What bone lives next to the scaphoid?
The lunate.
The lunate. That's correct. Okay, check it out. There are times, okay, and let me go back to my whiteboard here because I am going to show you guys one more thing here. We're going to kind of, yeah, okay, clear that. Okay, here's the deal. So as we know, okay, it's really important to know that the wrist itself, all right, is actually more stable in flexion than it is in extension. All right, so the wrist is more stable in flexion than extension. Okay, now, here's the deal. What that means, okay, is that a lot of our high energy trauma occurs with the foosh And what position is the wrist in a Fuchs mechanism?
Extension.
It's extended. Absolutely. Okay, so the wrist is going to be a little bit more unstable in an extended position. All right. Now, we already know, okay, that we have the scaphoid and the lunate that live next to each other. There's also a ligament that connects the two called the scapoliunate ligament. All right. Now, we call that the scapoliunate ligament or the SL ligament for short. Okay, now the space between the bones, and I'm going to draw that out here in a second. The space between the scaphoid and the lunate is called the scapoliunate interval. Okay. And if that interval gets disrupted, with a sprain, okay, we're going to actually, there's a couple things we're going to notice. You guys remember, and I know that I'm pulling stuff kind of out of nowhere from yesterday, but just a little bit of recall here in the lecture. You guys remember what the test was that we did yesterday that I kind of introduced to you guys? We hold the hand up like this, and we put our thumb between the scaphoid and the lunate, and we push. What's that called? You don't have to know the exact name. Just if you're familiar with it or you remember it, look, you shake your head. If you're familiar. Okay, so remember, right? That's Watson's scapoliunate. That's essentially Watson's test for scapoliunate instability. Okay, so with an SL ligament sprain, we're gonna have a positive Watson's test. Y'all, it's a miracle. My dog is sleeping. He never sleeps when I have class. So a positive Watson's test. All right, and then on radiographs, this is super cool. We're going to have something called a Terry Thomas sign, and I'm going to explain that in a second. It's actually kind of funny. Okay, give me one sec. All right, go back to my little pen here. I'm going to draw. So we know. All right. So here's my scaphoid again. So kind of a funky looking scaphoid. All right. There's my lunate. Got my scapoliunate ligament between the two. All right. So we already know scaphoid, lunate, SL ligament. Okay. Now the space in between. Whoops. Okay, that's the scapoliunate interval. Okay. But what if? Okay. What if the scaphoid and the lunate become disassociated from each other? Okay, what if I tear that ligament? So there's my scaphoid again. Woo. There's my lunate. But what I've done this time is I've actually sprained that ligament. Okay. And I've kind of torn it. All right. And now I've got an open space at the scapoliunate interval. Okay. So we'll have a positive Watson's test. And on radiographs, we're going to see something really cool called the Terry Thomas sign. Let me show that to you right now. You'll never forget this once you see it. All right. This is Terry Thomas. For those of you that have never heard of him, he was actually an actor. I can get this to pull up correctly. There it is. So he was actually an actor, and he was kind of known for having a gap between his teeth, his two front teeth. Okay, there's Terry Thomas with his infamous gap. All right. Now, this is called the Terry Thomas sign because just like the gap between Terry Thomas's teeth, right, we have a gap between the scaphoid and the lunate and a widened scapoliunate interval. Okay, so we have a widened scapoliunate interval on X-ray. All right, indicative of scapoliunate dissociation. All right, there we go. That is the Terry Thomas sign. Okay. Okay, now we've already talked about, and we know that The wrist is more stable. What, or more stable generally in what direction? Did we just say?
Flexion.
Less stable in extension, right? Okay, now here's the deal. If I go and I have a high energy Fuchs injury, again, right? It's also possible though, it may just not be my scaphoid or my lunate that's involved, right? I can have other carpal bones that are injured with a hyperextension, high energy injury, right? And generally speaking, okay, though, so I've got, dislocations that can happen. One of the most common dislocations is actually a dislocated lunate. Okay, so the lunate can actually dislocate. And if the lunate dislocates, what are we likely going to have anyway? What do you think will also be there? So if I'm less stable in extension, the lunate essentially dislocates, okay, palmarly like this. What ligament do you think will probably be injured in the process?
The SL ligament.
Yes, absolutely yes. You guys are so good. All right. Okay, so lunate dislocations. Okay, now here's the thing. All right. Because of the location of the lunate, right? The lunate itself is actually a very inherently stable bone. During really high energy traumas, okay, the lunate can dislocate, right, with extension. However, okay, another thing that can happen is that the lunate actually maintains its position of stability, okay, and the lunate actually does not dislocate, but the proximal row of carpals, being the scaphoid, okay, the lunate, the trapezium, and the pisiform, dislocate around the lunate. Okay, so sometimes that can also happen, and I'll explain to you what that is. Okay, in some cases, the lunate stays stable. And the scaphoid, okay, sorry for the triquetrum, and the pisiform actually disassociate around it, right? So they all actually dislocate volarly while the lunate stays in place. And that is actually called a perilunate dislocation because it's happening around the lunate. Okay. Yeah. Okay. Okay, so that's called a perilunate dislocation, guys, when that happens. And so let me actually, I'm going to pull up an x-ray of that and I'll show you. Okay, one sec here. Check this out. Oh, actually, you guys can't see that, can you? Okay, JK. Okay, let me share. Wow. Let me share. Bingo. Check. Oh, come on. You're killing me. Got so excited about that I clicked like 5 times. All right. There we go. Yay. Check out this x-ray. Okay. Notice the position of the scaphoid, okay, here. relative to the lunate. Okay, you see how the lunate looks like it shifted anteriorly? I'm sorry, how it shifted actually towards the palmar aspect of the wrist or anteriorly, right? So if you look here, you see how we've got a kind of a nice, the interval itself between the scaphoid and the lunate essentially disappeared, and the lunate actually has dislocated anteriorly. It almost kind of looks deep to the scaphoid, if you can see that. Let's look at a lateral view. Here's what a dislocated lunate, okay, looks like on a lateral view. Okay, so you can see here it is. Okay, the proximal row of carpals has stayed intact, and the lunate is dislocated anteriorly. All right, and you can see that here on the lateral view where the lunate is essentially just popped right out anteriorly. Reducing these it can be really, really difficult. Generally, what you have to do is you have to essentially put someone in a finger trap, where you essentially put their fingers in these little contraptions, and it holds them in a gravity-dependent position. And then you apply a lot of weight to the flexed elbow. And then what will happen is it essentially pulls the wrist downwards and basically causes a traction force that causes the lunate to actually relocate, right? And so there it is, okay? Again, nice straight line of the wrist, okay? There's the distal carpal row, proximal carpal row, and the lunate, okay? Anterior to that line. Okay, here's kind of another, and we'll move on to the next thing here in a second, but just one more question for you guys. All right, why do you think, okay, why do you think that it looks like the scapholunate interval has kind of disappeared here? Like it's kind of no longer there. What do you think? So do you guys, is that just, do you guys understand what I'm asking? Okay. Okay, so ultimately, right, with the scapholunate interval, right, when that lunate kind of dissociates anteriorly, you can see how the scaphoid is actually shifted medially a little bit. You see that? So the scaphoid actually shifted medially towards the lunate, kind of away from the lateral aspect of the wrist. Okay, so and just a couple little kind of points of demonstration here. Okay, so the difference though, as you guys can see again, right, between a lunate dislocation and a perilunate dislocation. Okay, here the lunate stays intact, and all the carpal bones actually shift anteriorly, whereas with the lunate dislocation, all the carpal bones stay intact and the lunate shifts anteriorly. Does that make sense? Perfect. Okay. All right. Hamate. Okay. We're going to, now, first of all, before we get into this next, this next pathology here, who remembers from yesterday, how to palpate the hook of the hamate? Show me. I'm listening and watching. So. Where do I find it? So remember my pisiform, we can find the pisiform. Okay, we shift it just kind of distal to the pisiform and a little bit medial. Sorry, a little bit lateral rather. Sorry, I misspoke. Okay, and we're going to find a really nice hook. Okay, right on the underside of the hand. All right, that's called the hook of the hamate. You guys feel it? We're going to go over this. We'll go over this again tomorrow in class, by the way. Okay. Hey, by the way, sorry, I'm going to kind of throw in a little something real fast. I'm kind of feeling that maybe it's time for like there to be like some breakfast or something supplied tomorrow for class, because it's just, I feel like it's been one of those weeks. I feel like all of us just we need a little pick me up or something. I can kind of feel that on a large level. And I kind of know that you guys, I think all of you guys are there too. The faces that I see this morning are faces that just look like you need a boost. So I too, all of us need a boost from time to time. So maybe tomorrow, God willing, I'll be able to stop and get something that I'll be able to bring. Although we can't eat in the classroom, so I'll just like put them in my office. I'm sorry, Bella, what?
I said that's stupid. No one will know. We
Okay,
do it all the time. No one cares.
okay. I can see Justine smiling too. She's like, I'd be okay with that.
We've ate stuff with Mary.
Okay, perfect. Then Mary did it. I can do it. It's fine. Okay, great. All right, guys. So look at the handmade again. Here we go. We can find that. All right. Now, here's what I want you to do. I want you to go ahead and I want you to flex your fourth and fifth I want you to flex your fifth finger. Okay. Put your finger right on the hook of the hamate. All right. And then go ahead and bend your pinky finger down. What do you feel under your finger? Tell me what you feel. By the way, there is no right answer to this. It's just, I just want to know what you feel.
I can like feel the movement underneath my finger.
Okay, the movement of what?
Feels like a tendon.
Yes, Bella, yes. It's a tendon. Okay, now remember, what did we say? Okay, kind of a little rule here. If we have a hook on a bone, like the hook of the hamate or the pisiform, what typically travels either around it or under it? Generally speaking, a tendon, right? So remember, if we remember the function of the pisiform, what it does, okay, if you hold your palm straight up toward the ceiling and you start to flex your wrist, once you get to terminal flexion, your wrist does this. Okay, that's the pisiform pulling the flexor carpi ulnaris tendon around itself, changing the angle of pull of the flexor carpi ulnaris. Okay, so same thing with the hook of the hamate. Okay, we have actually the flexor digiti minimi, and we have a flexor digitorum tendon that actually passes underneath the hook of the hamate, right? And so it's really important. Okay, if someone has a hamate fracture, if someone has a hamate fracture, okay, first of all, if someone has fractured their hamate, where are they likely to be tender? Anybody? Well, you guys are thinking, I'll give you a second. Where would it make sense that they would be tender? So, Brianna, Annika, Maddie, Emma, anybody that hasn't answered a question today?
To the fifth,
Okay, so they might be tender over the
more-
hook. I'm
a
sorry.
little more laterally.
Okay, so we're going to be looking really for tenderness right over the hook of the hamate too, right? If they have a hamate fracture, okay, it would make sense that they would be tender over the hamate. Now, really important, okay, when we're splinting and or casting a hamate fracture, okay, that we put the fourth and fifth fingers in flexion. Okay, why do you think it's important to put the fourth and fifth fingers in slight flexion with a hamate injury? What do you think we're trying to do?
Does it kind of stabilize the hamate?
Okay, very good, Bella. So, okay, flexing the fourth and fifth fingers shortens the flexor digitorum and flexor digiti minimi tendon and provides a little bit of added stability to the fracture site. Okay, so that's excellent. Yes, very good. Okay, so we're kind of, yeah, we've got about 17 more minutes. By the way, sorry, hope I didn't frustrate you guys. Sorry to call you guys out like that. Just was trying to kind of get a little bit more participation. Hopefully I didn't upset anybody. That wasn't my intention. So, all right. Here we go. So the next thing, okay, let's talk about the TFCC. Okay, we talked about this briefly yesterday. All right, TFCC. So what in the world is the TFCC, by the way? Okay. Sure. All right. So what is the TFCC? That stands for triangular fibrocartilage complex. You don't have to put a dash there, but ultimately you can see, okay, TFCC. Okay, so what exactly, we talk about the TFCC, what makes up the TFCC? All right. So I'm gonna draw this to the best of my ability. Okay, so bear with me. Actually, you know what? Even better. Sec. All right, it will stop. There we go. This will be a lot easier for you guys to see as opposed to me attempting to draw it. All right, check it out. Okay, so what makes the TFCC up? So the dorsal side of the wrist. Okay, when we think TFCC, we really need to know that we're focusing more on the lateral aspect of the wrist. Okay, and so ultimately, there is basically a disc of cartilage. Okay, it's called the articular disc, and that sits right between, okay, essentially the ulna, right, and the triquetrum on the lateral side. Okay, now within that articular disc, okay, there are actually ligaments, okay, that connect the ulna to the triquetrum. So the ulnar styloid, okay, we palpated that yesterday. There's ligaments that connect the ulna to the triquetrum, right? And not only that, right on the other side of the TFCC is the extensor carpial nares tendon. Okay, so if you find the hook of your hamate, right, and then you just drop in a little bit kind of on the palmar aspect, you're going to feel your ECU tendon literally right here. Okay, so okay, the TFCC, and I'll spell this out for you guys. I'm just kind of just give you the components of the TFCC. All right, that's what it looks like though. But let me go ahead and give you the components of it. Okay, so what makes up the TFCC? Okay, components of the TFCC. All right. So we have the articular disc. All right. So then after the articular disc, we have the, okay, number 2. Distal palmar radial lunate ligament. Okay, so here and here. All right, so there's actually a kind of an extrinsic ligament that connects the TFCC, that essentially makes up part of the TFCC on both the dorsal side and the palmar side. Okay. We already talked about the ulnar triquetral ligament. Okay, the ulnar lunate ligament. And then also we have the extensor carpial nares tendon, the ECU tendon. One of the things that can be difficult to kind of parse out when someone comes in with like lateral wrist pain, right? Is essentially whether or not this is actually a true TFCC injury or whether it's like an ECU injury, right? That can be what's the most difficult to kind of discern. Okay. All right. So then there's one last ligament actually that runs just below to the ECU called the meniscus homolog, right? It's kind of an odd name, but it actually is a ligament. It's not cartilage. Okay. So there's that. But what I'm going to do now is let's actually talk about how these present. Okay. When someone comes in to see you with a possible TFCC injury, okay, one of the first things they're going to tell you is that they're going to just complain of vague lateral wrist pain. Okay. So they're going to complain of vague lateral wrist pain. Often there's going to be there could be a mechanism associated. So there could be an MOI with acute injury. All right. The other thing, though, too, is that there may be repetitive microtrauma due to essentially repetitive like rotation of the wrist. All right. So one of the biggest things, too, that these people are going to complain of is pain with weight bearing through the ulna. And I'll talk about what that means. So for example, like if I'm going to get up from a chair, right? Or if I have, maybe I'm sitting on a couch or a bed, right? And I go to get up. Okay, I'm going to put my hands down on that surface and I'm going to push up. So ultimately, I'm going to stand up and show you guys this. So let's say this is the surface and this is my hand. If I were to push up using my hand, okay, that's going to elicit pain for a lot of these people that have TFCC injuries. So compression and rotation is going to be typically, that is weight bearing through the ulna, okay? Now, ultimately though, okay, yeah, what's up?
Could swinging a bat be like a repetitive micro trauma for this kind of injury?
It definitely could be, yes.
Okay.
So if you think about swinging a bat, Nico, too, right? Particularly when you follow through, like at the end of your swing, your top hand is pretty much in like maximal. Bella, are you laying down and swinging a bat? I wasn't sure what was happening. I thought you disappeared, but then I saw your hands randomly moving. Okay, but when you think about the end of your swing, you're kind of in maximal ulnar deviation, right? And then, particularly if you make contact with the ball, that bat is loaded, right? And so ultimately, you are providing a compression and rotation force through the ulnar wrist, right? Now, once again, though, remember, as part of the diagnostic process, we have to really kind of try to tease out, is this truly TFCC or is it more like an ECU type of injury? Does that make sense? Mm-hmm. Which can be that can be difficult to find to really kind of figure out, honestly. Okay, one last thing on the TFCC. All right, I know we're kind of getting this is kind of a little bit detailed here, but I'm going to draw you guys a picture. Okay, another picture. All right. Okay, we're going to talk about a concept. Oh, I already have my whiteboard up. What am I doing? We're going to talk about a concept known as ulnar variance. You guys, by the way, can you guys hear me? It says that my connection's unstable. Am I breaking up and freezing? So. Okay, awesome. Okay. All right, so let's talk about first of all, what in the Sam heck is this concept of ulnar variance? So when we look at the DRUJ or the distal radial ulnar joint, okay, here's my radius, big old radius right there. Okay, it's a really big radius. Okay, and then I have my ulna, my little styloid. Just like that. Okay. So what, by the way, what articulation is this called? You guys remember from yesterday? What's this called? Name that joint.
Distal radial ulnar joint.
You got it. The distal radial ulnar joint or the DRUJ. That's not a D. That's a D. Okay, distal radial ulnar joint. Okay, now, at least for the sake of argument, we're going to say that the height of the ulna compared to the radius here is level, right? That those are essentially the same height. What happens though, because this does happen anatomically, okay? What happens though? All right, radius. Okay, but now got my ulna. Okay, but here it's definitely not level. So my ulna exceeds the height of my radius and surpasses it. Okay, what in the world is this called? This, and you will see this, is called positive ulnar variance. Positive ulnar variance. Okay. Hang on, I'll let you guys write that down. My dog is whining at the back door. Okay, so that's positive ulnar variance. Okay, now let me know when you guys have that. I see people still writing. Okay, conversely, just like we have positive ulnar variance. Now, first of all, before I go on to the next one, why would it make sense to you guys, or let me just ask, does it make sense to you that positive ulnar variance is actually a risk factor for TFCC injury? Okay. If that makes sense to you, why does it make sense to you?
Is it because if the ulna is taller, then it basically shifts your hand this way more, which puts more tension on the ligaments?
Yeah, it's ultimately, yeah, Bella, ultimately what happens is when you have a positive ulnar variance, it increases the compressive force, right? It increases the compressive force on the TFCC due to the decreased distance between the ulna and the hand. Okay, so it essentially, it increases the compressive force between the ulna and the hand, right? And with that more prominent ulnar styloid as well, can kind of cause potentially more ligament or cartilage injury with rotation in that case, right? Now, conversely, so we've got positive ulnar variance, radius. What do you guys think this is called? Somebody said it, but I think you were muted.
Radial variance.
Okay, okay, I like it, negative ulnar variance. So we have positive ulnar variance where the height of the radius or the height of the ulna exceeds the radius. Then we have negative ulnar variance. Okay, where the ulna is actually a little bit shorter, right, than the radius itself. So that is negative ulnar variance. So we are getting close to time. I think it makes sense to have this be the kind of the last thing we covered this morning. I'll let you guys finish getting that down. Okay, one sec here. All right. Okay, guys. So ultimately, yeah, that's pretty much it for today. Yeah, so ultimately you guys also, and first of all, I apologize for this, and it's taken me way too long, but the exam is nearly finished and the study guide is nearly finished. I'll have that posted by tomorrow. Okay, you guys will have a full week to get that done per normal. All right, so anyway, I'm sorry that that's taking forever, but yeah, so there's that. Any other questions at all before we call it a morning? No. All right. Okay. You guys need anything? Are there any needs, any questions, anything that's on your mind? Anything that, no? Okay. All right. Well, hey, you guys are great. All right. And if all goes as planned tomorrow, which that doesn't really happen ever, but if all goes as planned, hopefully there might be maybe some breakfast or something tomorrow, because it's Friday and I feel like everybody needs a little something. So yeah. Okay. But you guys are awesome. Okay. Keep hanging in there. And I'll see you guys tomorrow morning. If you need something, please let me know. All right.
Thank you, Wade.
Yeah, you bet, guys. Oh, hey, by the way, just bye. Blip, 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 blip.